In our second video about the therapeutic options for osteoporosis, we'll encounter vitamin D and parathyroid hormone, the principal hormone regulators of calcium and phosphate homeostasis, both of which can be administered exogenously in various forms. Unlike the drugs featured in the previous video, which treated osteoporosis by blocking bone resorption, the agents we'll cover in this video increase bone formation and increase bone mineral density for the duration of treatment. So let's head out to the paleontological dig site where we can observe, firsthand, the osteobuilders constructing those massive skeletons we saw back at the Natural History Museum. See how the osteobuilders are in the middle of reassembling that Allosaurus fragilis skeleton? Remember that osteoblasts are your builders, the cells responsible for depositing hydroxyapatite into the bone's organic matrix. That means building bone. In the last sketch, we didn't really focus on osteoblasts because we were trying to block the breakdown of bone. This time, however, we're going to show you a couple agents that are responsible for directly stimulating these osteobuilders, thereby promoting bone formation. Osteoclasts, remember, are the cells responsible for bone resorption. So just like last time, osteoclasts will be represented by these classmates here on a field trip to the dig site. This time, they're responsibly destructive. Don't worry. See? They help break down the fossil beds, which gives the osteobuilders the necessary products for bone formation. Bone resorption by osteoclasts leads to the release of calcium and phosphate into the bloodstream, two important ions for general cellular function. In this sketch, calcium will be represented by those calcified bone fossils, and phosphate will be represented by little prehistoric pea-shaped shell fossils. It's now time to introduce one of the main hormone regulators of calcium and phosphate homeostasis, parathyroid hormone, or PTH. At Sketchy, PTH is represented by a scientist with his PhD in paleontology. That's right. He's in charge of this whole fossil resorbing and bone-building operation. Let his makeshift laboratory out in the field represent the parathyroid gland, where parathyroid hormone is synthesized and released. Take a peek inside, though. It looks like our PhD paleontologist is a little overwhelmed at the moment.
I don't know. It's a femur? This is way harder than Sam Neill made it look.
Yeah, it looks like he won't be back out in the field anytime soon. Let this backup of calcified bone specimens, keeping the PTHD occupied, represent calcium's ability to act directly on the parathyroid gland to reduce PTH production and secretion. You see, there's a calcium-sensing receptor on the parathyroid gland that responds to increased serum levels of calcium. And this receptor is embodied by this calcium receptor conveyor belt leading to the laboratory. So to release PTH from your parathyroid gland, I want you to think of the opposite. In other words, low serum calcium will increase PTH levels in the bloodstream. Let's look at a few of his activities once he's out in the field. Let's start with those osteoclast classmates. It turns out that he can activate them. He does this indirectly, however. PTH stimulates osteoblasts to produce rankle, just like our PTHD here, convincing one of the osteobuilders to hand over this rankle crank drill. I think the little guy's ready, don't you? Here's looking at you, kid. And as one of the classmates grabs onto the rankle crank drill, think of rankle binding to rank of the surface of the osteoclasts to increase their differentiation and activity. To sum it all up, remember that PTH tells osteoblasts to activate osteoclasts. Okay, that's bone resorption. What about bone formation? Let's head over to the osteoblasts. PTH stimulates bone formation by stimulating the maturation of pre-osteoblasts into functional osteoblast builders. This is represented by our PTHD paleontologist teaching the premature osteobuilders Bone Formation 101. And before you know it, they're mature enough to head out into the field and start building. So although both bone resorption and bone formation are enhanced by PTH, the net effect of endogenous PTH is to increase bone resorption. Remember, it's released from the parathyroid in response to low serum calcium. So the goal of PTH is to boost those calcium levels. Besides activating bone resorption, PTH also works to increase serum levels of calcium in other ways. At the kidney, for example, it stimulates calcium reabsorption into the circulation. This is represented by our PTHD at the kidney-shaped crater, where he gathers up the calcium fossils to study. This is at the expense of phosphate, by the way. PTH actually reduces phosphate reabsorption at the kidney. Notice how he picks out the calcified bones, but leaves the little phosphate shell fossils behind. So remember that the net effect of PTH is to increase calcium levels and decrease phosphate levels. The last way PTH increases serum calcium is by increasing the production of 1,25-dihydroxyvitamin D. This is all happening at the kidney. 1,25-dihydroxyvitamin D is also called calcitriol, and at Sketchy, that means a cute calcitron robot. With the help of PTH, calcitriol is the other important hormone for increasing calcium levels in the circulation. Before we discuss vitamin D, though, let's finish up our discussion of PTH by introducing a drug that acts just like PTH, teriparatide. There's one important distinction to make here, however. While the net effect of endogenous PTH from the parathyroid is bone resorption, administration of exogenous PTH, i.e., teriparatide, in low and intermittent doses actually increases bone formation without all that osteoclast activation getting in the way. Teriparatide is a smaller, recombinant form of PTH that takes advantage of these anabolic actions and can therefore be used as a treatment for osteoporosis. If PTH is a PhD, teriparatide is like the TA who follows him around. His first assignment? Helping out with osteoblast differentiation and maturation at the Bone Formation 101 course. Notice, too, that he holds our recurring symbol for osteoporosis treatment, a fresh new piece of calcified chalk. Teriparatide's ability to stimulate osteoblasts leads to new bone formation and decreased risk of fractures in patients with osteoporosis. Notice that the teriparatide TA is not out in the field with the destructive osteoclast classmates. He stimulates bone formation, not resorption. Teriparatide can help bring calcium into the circulation in other ways, though. For example, he can help the PTHD paleontologist at the kidney dumping site where he exerts similar effects as PTH. In other words, he increases calcium absorption at the expense of phosphate. This gets more calcium into the circulation. Teriparatide also acts just like PTH by increasing production of calcitriol at the kidney as well. See? We've got a brand new calcitron robot, ready for work. This calcitron robot is a pretty advanced piece of paleontological technology, but where did its precursors come from? To show that, we're going to have to get back to vitamin D. Remember that vitamin D can refer to either ergocalciferol, vitamin D2, or cholecalciferol, vitamin D3. Cholecalciferol can be obtained through the diet by eating, or it can be produced in the skin under ultraviolet UVB radiation found in sunlight. Notice that these D3 batteries are powered by the sun. So for cholecalciferol, think solar calciferol. But also notice that the cart is being pulled by a dairy cow to remind you of vitamin D3-rich dairy foods. Just a couple more steps, and this vitamin D3 solar-powered battery will be converted into a fully functioning calcitriol robot. Ergocalciferol is the other vitamin D. It's found in plants and therefore can be obtained in the diet. In this scene, it's represented by this earth-friendly battery, which means it's probably recyclable or compostable, maybe? Anyways, think earth-friendly ergocalciferol. We've even put them under the trees to remind you that vitamin D2 is found in plants. Next, we're going to show how vitamin D is activated into fully functional 1,25-dihydroxyvitamin D. And to do this, we'll use the vitamin D3 solar batteries as an example. But remember, the exact same steps will also convert that vitamin D2 battery into a fully functioning calcitriol robot. The first step is the 25-hydroxylation of vitamin D to 25-hydroxyvitamin D. This is represented here by adding a body to the vitamin D battery. This happens in the liver, hence the hepatic wheelbarrow used for transport. Next, 25-hydroxyvitamin D is metabolized in the kidney to the active hormone, 1,25-dihydroxyvitamin D, or calcitriol. As we discussed previously, PTH stimulates this process. Think of the last hydroxylation step as the last attachment, a robot head that converts the original vitamin D battery into a fully activated calcitriol robot.
Johnny 125 is alive.
We even included a number 1 antenna on the head to remind you that the 1-hydroxy is added last. Now that calcitriol is ready, the paleontologist can send the robot out to do his bidding. Just take a look. The calcitron robot is already much more productive than the paleontologist at the kidney. Psh, silly humans. With its large, capable bionic arms, it can gather both calcified bones and those pea fossils. Yep, calcitriol increases reabsorption of calcium and phosphate at the kidney, increasing their availability in the serum. 1,25-dihydroxyvitamin D is also a potent stimulant of intestinal calcium and phosphate absorption, shown here by our calcitron robot retrieving both calcified bones and phosphate pea fossils from the newest shipment of specimens. Notice that the side of the transport truck resembles the GI tract. Like PTH, calcitriol can also induce rankle in osteoblasts and is a potent stimulator of bone resorption, releasing calcium and phosphate into the bloodstream. That's why the calcitron robot is helping the PTHD distribute those rankle crank drills to the osteoclasts. So overall, calcitriol is activating osteoclasts and osteoblasts, just overall bone turnover. 1,25-dihydroxyvitamin D also exhibits negative feedback by acting on a vitamin D receptor in the parathyroid gland, inhibiting the production of PTH. Remember that excess calcium was keeping the PTHD occupied in there, inhibiting his release. Well, the calcitron robot isn't helping much either, just trying to please his master with a new bone specimen.
Special delivery.
He inadvertently runs over the side of the parathyroid tent, trapping him even further.
Apologies, Master.
And finally, just like PTH, calcitriol also promotes the proliferation and differentiation of osteoblasts. This mechanism, along with the increased intestinal absorption of calcium, makes vitamin D supplementation a useful component of osteoporosis treatment. So we've drawn in the calcitron robot aiding the PTHD in teaching those osteobuilder precursors, holding a fresh new piece of calcified chalk. I want to emphasize here that either vitamin D, those ergocalciferol and cholecalciferol batteries, or calcitriol, the calcitron robot, can be administered therapeutically. Vitamin D won't have as much of an effect in the setting of renal disease, however, because it needs to be turned into calcitriol first, which requires a functional kidney. Okay, now that we know all of the physiologic actions of vitamin D and its metabolites, let's discuss a few of the other uses of vitamin D. A nutritional vitamin D deficiency, either due to decreased dietary availability or decreased sunlight exposure, leads to rickets in children and osteomalacia in adults. The utility of vitamin D in preventing these disorders is represented here by our friendly calcitron robot, stabilizing this rickety old water tower. Notice, too, that the tank of the water tower looks like a cracked, failing kidney. Patients with chronic renal failure will not be able to synthesize 1,25-dihydroxyvitamin D, which can lead to hypocalcemia. Therefore, vitamin D therapy is useful in these patients. Remember, though, it has to be given as calcitriol. Regular old vitamin D isn't going to cut it. A non-functional kidney will not be able to turn vitamin D into active 1,25-dihydroxyvitamin D, so we just give them the active form directly instead. All right, take a close look at that worker up there, wearing some pretty conspicuous knee pads and elbow pads. These represent the plaques that form on the elbows and knees of patients with psoriasis. Psoriasis is a common chronic inflammatory skin disorder characterized by sharply demarcated, salmon-colored, rounded plaques covered with a loosely adherent, silvery white scale. How's that for a description? The most common affected areas include the elbows, knees, lumbosacral area, and the scalp. Topical vitamin D therapy can be useful in these patients to inhibit keratinocyte proliferation. One last therapeutic use of vitamin D to mention. It can be used for the long-term management of hypocalcemia. Hypocalcemia is represented here by these calcified bones falling from the hands of this paleontologist here. Calcitron robot to the rescue.
More than meets the eye.
Hypocalcemia is commonly caused by hypoparathyroidism, which is why we have included a falling PTHD badge. Low PTH means decreased production of calcitriol in the kidney and decreased absorption of calcium from the GI tract, just low calcium all around. So we've got to supplement calcitriol exogenously to absorb that calcium. Note, however, that vitamin D3 and D2 will be less effective here because no PTH means reduced activation of vitamin D by the kidney. I also want you to notice that the PTHD's bow tie is undone. The undone bow tie represents surgical trauma to that bow tie-shaped thyroid gland. The inconspicuous parathyroid glands can be injured during thyroid surgery, causing post-operative hypoparathyroidism and hypocalcemia. Lastly, notice that the whole structure is shaking. Those shaky motion lines are our recurring sketchy symbol for seizure. Mild hypocalcemia can cause paresthesias and cramps, but more severe hypocalcemia can lead to trismus, tetany, changes in mental status, and generalized seizures. Symptomatic patients can be treated with IV calcium, but if the hypocalcemia is due to hypoparathyroidism, remember to supplement with calcitriol for long-term management. Since both teriparatide and vitamin D increase serum calcium, there's a chance of causing hypercalcemia, so make sure to keep an eye on those calcium levels. Hypercalcemia is represented here by our recurring sketchy symbol, an elevated cup of calcium ice cream. A toast to another successful day at the dig site.
I cannot compute emotion.
The last drug we'll cover affecting calcium homeostasis is cinacalcet, represented by this worker calculating the calcium entering the parathyroid gland. A cinacalcet calculator, if you will. Cinacalcet is a calcimimetic that allosterically activates the calcium-sensing receptor in the parathyroid gland. In other words, it tricks the gland into thinking there's a lot of calcium around, thus inhibiting parathyroid hormone release. The bone receptor conveyor belt will represent the calcium receptor. This is where cinacalcet does his thing. See that calcium bone buildup at the parathyroid tent, though? Cinacalcet treats the hypercalcemia associated with primary or secondary hyperparathyroidism in patients with chronic kidney disease. Remember, it's acting directly on the gland to inhibit PTH release. He'll keep him occupied for a while. All right, let's wrap up this sketch with one more drug, sevelamer, represented by the sevelamer shoveler. Sevelamer is a non-absorbable phosphate-binding polymer that decreases absorption of phosphate in the GI tract. So we've put him in the GI tract transport truck, binding those phosphate P fossils. See that big pile of phosphate fossils? Sevelamer is used to treat hyperphosphatemia, another common complication of renal failure. All right, the sun is starting to set, and I can just feel the vitamin D deficiency setting in. So I just wanted to briefly sum up this sketch by reminding you about the actions of PTH and vitamin D. That PTH-PHD works at the kidney to increase calcium absorption and activate vitamin D. It also activates osteoblasts and indirectly osteoclasts. Overall, it causes increased bone resorption and boosts serum calcium levels. The teriparatide TA acts much like PTH, except with intermittent administration, it actually skips that whole osteoclast thing, so it helps build bone instead of break it down. Vitamin D is a whole nother machine. Once activated by the kidney as calcitriol, it works at the kidney to reabsorb both phosphate and calcium. It also works at the GI tract to reabsorb, both phosphate and calcium. It activates osteoblasts and osteoclasts as well, so bone turnover is increased. Oh yeah, I forgot to mention, calcitron's last use? An accessory to your Nintendo Entertainment System. 1985, son.